Cardiac surgery was the main mechanism to treat people with tricuspid regurgitation. About 6 years ago at Northwestern, we started with transcatheter therapies through early feasibility, through pivotal trials, through continued access, and now commercial opportunities. A large proportion of patients with tricuspid regurgitation can be treated with valve replacement and is a real huge adjunct to those that can be treated with edge-to-edge repair.
However, in patients with a pre-existing right ventricular pacing or defibrillator lead who undergo transcatheter tricuspid valve replacement, the process of putting the new valve in entraps or jails that pre-existing lead. And the outcomes of these jailed leads to date really hadn't been known. Here at Northwestern, we worked with colleagues from Europe to do a 3-center study on the outcomes of these entrapped leads that has recently been published in JACC Cardiovascular Interventions. Among 52 patients with entrapped pacing or defibrillator leads, there were 4 major complications. 1, immediate lead dislodgement during the EVOQUE deployment procedure. There were 2 ICD lead fractures leading to inappropriate shocks, and 1 case of MSSA bacteremia with a confirmed vegetation on the jailed lead and inability to extract that jailed lead. Of the other 48 patients, there were no lead-related complications. There were 46 patients who had clinical follow-up greater than 30 days after the procedure, and again, there were no clinically significant lead-related complications among those patients. We had follow-up data on lead parameters on 33 patients greater than 30 days. Among this subcohort, there was no change in sensed R waves, but a statistically significant decrease in pacing impedance and statistically significant increase in RV lead pacing capture threshold through the duration of follow-up, which was just over 1 year. However, it's important to note that despite these statistically significant changes in lead parameters, no additional patients necessitated a lead revision due to these electrical changes.
We were also able to demonstrate that we almost had complete abolition of tricuspid regurgitation, as has been shown in the native valves without pacemaker leads. So that was very reassuring. But 2 things we found from transcatheter tricuspid valve replacement is 1, the incidence of needing a new pacemaker is at least double, if not triple that than what we've seen with TAVR. And also, we want to know how to best manage patients that have an indwelling pacemaker lead. Having the expertise of our electrophysiologist joining us on all of our heart team meetings is critical to really ensure best patient outcomes.
This project is a true multidisciplinary effort, both here at Northwestern and internationally with our colleagues. We want to extend some great thanks to all the collaborators who helped us with this project and look forward to the next steps. Thank you.